type 2 diabetes is no longer a permanent disease.
So, Professor Mike Lean, thank you very, very much for joining me at Stress Free Longevity. Usually, we just start with a little bit of a basic introduction to yourself. Do you mind just letting the listeners know where you're based, what you do, and what your kind of key research interests are?
Okay, my name is Mike Lean, and I'm a general physician, um, and I'm also a specialist. I'm on the specialist register for diabetes and endocrinology, and also for human nutrition. In fact, I think I'm the only doctor in the UK on the GMC specialist register for human nutrition. I don't think there's anybody else. And that tells you kind of where I sit. What is human nutrition? Well, it's everything which is not in human nutrition. And I guess my main focus in research has largely been around type 2 diabetes and the big driver, which of course is appetite and obesity, not only for diabetes, but for a whole raft of chronic diseases. And this has kind of become a major issue during my professional career, having been a relatively uncommon condition previously. It's now the big one facing economies across the world, and particularly now in the low-income countries.
And we're going to focus on type 2 diabetes. Just with respect to that, are there any financial disclosures that are relevant?
No.
Well, listen, we like to start with a little bit of basic science, if that's okay. Do you mind just telling us what is diabetes or type 2 diabetes, and what do we now know about how and why it occurs?
Yeah, and this question is entirely appropriate for time present. I was brought up to understand that type 2 diabetes was quite a mysterious endocrine condition that involved malfunction of the insulin in the body and cells not functioning properly. I was told it was permanent, you have to take medication forever, and it was also inevitably progressive with a whole raft of horrible complications. And it was also quite rare. What's changed is it's now become very common. It's happening in younger people. The complications are much more vivid and occurring, in people's working lives. Um, and we've understood that it's not actually a primary endocrine condition at all. It's a condition which is pretty much entirely driven by your genes, and you can't do anything about your genes. But if they are the sort of genes that put you in this direction, and you put on weight during your adult life, then diabetes will reveal itself together with the other cardiometabolic conditions: hypertension, dyslipidemia, premature heart disease, kidney disease, polycystic ovarian disease. They all go together as part of a kind of pattern of diseases driven by putting on weight. And what we've learned, and it's our recent research in the last 10 years have taught us this, that it's not just putting on weight full stop. It's actually putting on weight and putting the extra fat into your vital organs. So when people gain weight, generally you put that extra weight into the cuddly places, the places you can touch, hold, grab. That's safe enough. You may not like it, but it won't do you metabolically any damage. If you, on the other hand, put that extra fat into your heart, into your liver, into your pancreas, into other vital organs, they will malfunction. That is what's happening behind type 2 diabetes. And we've also learned from our recent research that if you can help people to lose the last bit of weight they gained, they don't have to lose all the extra weight, lose the last bit of weight they gained, that will sort of suck out the fat from those vital organs and allow them to function better or even normally again. And that's a huge learning, because type 2 diabetes is no longer a permanent disease. It's something which, if we identify it early or even get it at a pre-diabetes stage, we can stop the progression by sufficient weight loss, and it's quite a bit of weight loss for most people, to remove that extra fat, which is now going to start doing damage to vital organs.
And do you mind just touching on a little bit more about why it's becoming so prevalent? I've seen some of your lectures, I've seen the charts. It has exploded in the last 20 years. Now, presumably our genes haven't changed significantly. Presumably we're not exercising significantly differently in that time, but presumably our food environment has changed. But what do you feel is the primary reason, or is it just a multitude of factors at play?
It's a sort of perfect storm of developments within society towards labor-saving devices, activities. We are exercising less than our parents, less than our grandparents, much less than our great-grandparents. And this has all happened within the last 100 years anyway, that people have found it possible to mechanize all sorts of activities. You don't even have to clean your teeth anymore. There's a machine that does it for you. Hoovering around the house, washing clothes, cutting sticks and carrying water, the things which normally were part of life and would contribute to burning up a few calories. This has all been taken over by mechanization. At the same time, we have unleashed a basically unregulated food industry, which has the the profit-directed motive of selling more, whatever the outcome. And the food industry has been incredibly successful. Social marketing of food, individual foods, food in general, but specific foods. And we think here of the what are called high value foods, which means high value for the investors and the manufacturers, not high value for the consumers. And these things like your chocolate bars and your snack bars and your anything which qualifies as a snack. Archetypally, your ice cream, which is just fat and sugar jammed together. These are added value. They are very, very cheap foods to produce. You spend a lot more on the packaging and that sort of thing. Added value, high value foods for the manufacturers, but they are throwing extra calories into people at a time when they're actually exercising less. And that's the sort of perfect storm. And we've seen that happen gradually over 2 or 3 generations in Europe. What we're seeing in the low-income countries is all this is happening within one lifetime. So we find, for example, my work in Nepal, I've met villagers who saw the first wheeled vehicle arrive in their village, usually a bicycle. And what did it bring? It brought Coca-Cola, it brought sticky sweets, it brought chocolates. And they have seen this kind of switch from a total agrarian life into one where it's possible to sell what you have, buy cheap food, and get fat, and that's what's happening. And it's an absolute tragedy.
Is there an easy way for you to break down what is happening pathophysiologically, just in a basic sense? I used to think it was insulin resistance, but you've mentioned there it can be this accumulation of fat around the pancreas and other organs. What is actually happening internally?
There is an element of insulin resistance, and that was recognized back in the 1930s. So there are some people who don't respond as well to insulin as others. And part of the reason for that is that they have accumulated fat in the organs that should respond to the insulin. So your muscle, your skeletal muscle that you use or should use every day for running around, jumping, so all those muscles, what is happening is that fat starts to accumulate within the cells of your muscles, within the cells of your liver, within the cells of your heart. And the fat inside those cells, we call it ectopic fat. It shouldn't be there. Physiologically, it should not be there. Fat should be kept in your adipose tissue, and it's pretty well safe metabolically while it's in adipose tissue. When it gets into the vital organs, it's going to do damage locally. Exactly how it does that is still a bit of an unknown, and it's probable that there are certain types of fat which are more hazardous than others. So this is getting a bit technical, but people might have heard of palmitic acid. People have heard of palm oil as being a horrible product of destruction of lands in the Far East to make more calories to put into your ice cream and stuff. In normal diets, we have a certain amount of palmitic acid. If you get an excessive amount, and actually this largely comes from what is made within your own body yourself, it has to be put somewhere, and that seems to be a particularly toxic type of fat. So this is a little bit technical, but basically, as soon as people start putting fat into their vital organs, it's going to start doing damage. Exactly how it does that at a subcellular level, I think it'd be fair to say we don't know, but we think certain fatty acids might be more hazardous than others.
And who is at risk? Is this universal? Are we all at risk if we eat enough and put on enough weight, or are others more at risk than others?
It used to be said that if you live long enough, pretty much everybody will get diabetes. You live long enough and put on some weight. But there are pretty clear genetic markers. So, for example, people who are from Asian or indigenous backgrounds are much more prone to diabetes, to putting the fat into the vital organs at an earlier, younger stage when they're not so much overweight. So there are clearly big differences between individuals in the timing and the stage at which they will start, as I say, putting fat into the vital organs to do damage. And it happens at different levels of fatness. So some people, especially Asians, will start putting fat into their vital organs when they're not visibly overweight. They might have a body mass index of 22 or 23, which falls within what we would call the normal range. It isn't normal from a metabolic perspective, especially not if you are of Asian origin or indigenous origin. So there's quite a big range. To be able to say who is at risk, long before this is all happening, we do have pointers. Obviously, family history is important. If you have type 2 diabetes in your family, then genetically you are likely to be closer to it than somebody who doesn't have diabetes in the family. If you have diabetes in your family with relatively low levels of obesity, then again, that means that the risk is likely to be higher. If you're from an Asian or indigenous background, traveling people, there's a whole number of groups who we know have higher risks for genetic reasons. We don't know exactly what the gene is, and we can't do anything to get rid of that gene, but we know some people are at higher risk than others. Women who've had gestational diabetes during a pregnancy are very likely to go on and develop diabetes if they become overweight or remain overweight later on. And we can get pointers from blood tests at different times. So stress, put any kind of stress, whether it's a broken leg or a severe infection, sometimes will push up the blood glucose in otherwise perfectly fit people, and that tells us that they are likely to go on and develop diabetes at a later stage. And it's possibly because those people have a lesser secretion of insulin than the rest of us. So that may be genetic. And one of the features that we see in the offspring of people with diabetes, that their children have a lesser first phase of insulin. So if you take a big slug of sugar, a mouthful of Lucozade or something, your pancreas will normally put out quite a lot of insulin quite quickly. And that's the sort of healthy first phase insulin. In people with type 2 diabetes and their children, that is reduced. So that may be part of the genetic baggage that people are carrying who are then at risk of developing diabetes and its complications later on. The diabetes itself, that the high blood glucose, it does do some damage. Of course, it does some damage. And we know that running with a high blood sugar does damage to your eyes, to your kidneys over a period of time. It's over quite a long period of time. We're talking, many years probably before visible damage occurs. But what we know now is that is a signal that you're accumulating fat in these vital organs, and not just in one vital organ, but across the board, which will gradually do damage to other parts of the body. So people with diabetes who may have no symptoms at all are likely to develop premature heart disease, kidney disease, hypertension, and the complications of all these things, because it's part of a general pattern of metabolism. And it's something which we can't take away the genetic background, but what we can do is to modify the amount of fat that you put into your body, the amount of fat you accumulate. What we'd like to be able to do is to specifically remove the fat from the vital organs, where it's got into the cells of your liver, got into the cells of your heart. We don't have a way to do that yet, but of course the drug industry is very keen to find a clever trick to allow you to get fat and not get the complications. There's a philosophy attached to this. Is that a good use of the world's resources, or would be better saying, look, the food industry has had it easy for a very long time. Perhaps we ought now to say no to some of the things which are clearly driving the epidemic. And in my terms, the big driver is snack foods. I remember the days when I was at school, we would have been punished if we were seen eating between meals. Snacking was not a thing. There were no snack foods. They didn't exist. But now there's a massive industry, and you have whole shelves of supermarkets selling snack foods. What are you meant to do with them? Well, you're meant to add them to your meals. And not only that, you're meant to send your children to school with snacks. And this is a catastrophe. It's a free market, so they're not breaking any laws by doing it, but they know jolly well this is going to cause people to put on weight. They know that some of those people will go on to develop diabetes and its complications, and they know they'll make more money if they can get children to start young and eating snacks early on and do it for the rest of their lives. So on average, in the UK, people now are eating somewhere around 300 or 400 calories every day more than our parents and grandparents did at the same age, same stage. And that's jolly good to the food industry, but it's not good for health.
Now, why does the diagnosis matter? What does the diagnosis mean in terms of longer term health and longevity? And maybe one way to frame it is, if you were, giving the diagnosis to a newly diagnosed type 2 diabetic in your clinic, what would you tell them about the prognosis if left untreated?
Tremendous question. And of course, as a hospital specialist, I'm never in that position. I wish I could be. But what actually happens is that people, either they're getting a routine screening or they've got something wrong with them and they get a test, and it comes back and says that they have diabetes. Often it's the nurse who sees it first and speaks first to the patient. It's often not a GP. Sometimes it's a GP. And I'm afraid what is happening across the country is pretty much the same as has happened for the last 100 years, which is, your tests have shown you have type 2 diabetes. Don't worry, we can give you a tablet and you can come back in a year's time. And that is wrong, wrong, wrong. That is the wrong advice, because that simply allows the disease to progress. The tablets push down the blood sugar, cover up the disease, and the disease, which is the fat accumulation in vital organs, progresses. Now, your doctor or nurse may say you should attend to your diet, you should try and lose some weight. Well, that's nice in principle, but that's not enough. That doesn't actually do the job. And we know that most people, until very recently, most people did not lose very much weight, and they carried on, and the disease then progressed as we were taught, and produced all its complications. Now, if I were to turn the tables forward to the year 2025 and put myself in that position, I would say to my patients, the test has shown that you have type 2 diabetes. Maybe that explains whatever the problem was, why we're doing the test. What this means is that you have a very high risk condition, which left unchecked will cause multiple complications over a period of time. They're not good complications, they're disabling and they're painful, and we can't treat the complications. Once you've got them, they will progress. However, the disease process, this thing we call type 2 diabetes, is a part of a more global process that causes many other diseases, which is to do with putting on weight and putting that weight into the wrong places. And we can help you. So we can help you by helping you to lose some of your excess weight. And we're talking stones rather than pounds here. And we're talking 1 or 2 stones is usually enough to get rid of the diabetes completely, and also to reduce your blood pressure, or to avoid the risk of high blood pressure, and also to reduce the risk of heart disease. And we've got good evidence that all these things happen. And you could broaden it depending on your patient. If the patient also has polycystic ovarian disease, or also has kidney disease, other conditions tied into their weight, many of them will get better if you can lose a substantial amount of weight. The old days, we used to think that losing 3 or 4 pounds was good, or 3 or 4 kilograms was good, and we had a sort of idea that 5% of weight loss was a nice target, because that's what the average dietitian could achieve just by giving some simple advice. That isn't enough, at least not for European people. It's actually remarkable how that can change life for somebody with an Asian origin. But for most European people, they're going to need to lose a couple of stones in weight. And most of them, by the time they have diabetes, are several stones overweight. Actually still be overweight, having lost 2 stones. But that is enough to get rid of the diabetes. And we know from other evidence that getting rid of the diabetes will reduce the likelihood of having a heart attack. And we've got good evidence that it'll normalize your blood pressure in many cases. So this is the patter from the nurse or the GP should be saying, yeah, you've got a serious condition, but we can help you and we can put it right. And so you need to be very confident that this will work. When you say very confident, we know that pretty much 9 out of 10 cases will get rid of their diabetes if they lose that 15 kilograms in weight. That you can be very confident.
Yeah, you've alluded to it there. That was my next question. It was presumed to be this chronic condition that you were now lumped with for the rest of your life. But you were lead investigator in the DIRECT study, which has really been quite transformative in this practice. You've mentioned some of the obviously the benefits that have come from that, but would you mind just giving us a little bit more about the DIRECT study, what you did and what were the key findings?
Yeah, the DIRECT study was hugely important, and it came about by conjunction of really 3 things. 2 people, me and my old pal Roy Taylor down in Newcastle, and we've known each other since the day we qualified and started practice in medicine in the same hospital. That was in Edinburgh long, long ago. But more importantly, it came at a time when a survey was carried out amongst people living with diabetes by Diabetes UK, which asked them, what would you like us to do in research? We're doing all this research to try and help people, but we've never actually asked people with diabetes what they want. So that survey, which was led by Sarah Finer and included people with diabetes who Paul Robb was one of the co-authors of that, who himself had type 2 diabetes. They went and asked large numbers of people, what do you want us to do in research? And they said with one voice, number 1 priority, we want to know if it's possible to get a cure or remission. And they used the word remission of type 2 diabetes. And how do we do it? So I had been making observations myself over many years, and I'd done some research long ago into fat accumulation in specific organs. So I kind of knew vaguely what was happening, or even quite precisely what was happening. And my colleague Roy Taylor had also seen patients, some of them, lose weight and get clear of their diabetes. Now, we were both told, in very succinct terms, these were rare, odd, unusual cases, and that everybody else would just continue to have diabetes and it would be progressive. And I said, no, I don't think so. I think if we lose enough weight, we can actually get on top of this disease. And Roy Taylor had agreed with this, and he'd done a small study looking at some mechanisms around what happens to the insulin function during weight loss. So we got together, we designed a plan with the help of people with diabetes. Paul Robb himself was one of the steering committee. And we said, right, we will take ordinary people with type 2 diabetes quite early in the first 6 years, so not leaving it long enough to cause really serious damage. 6 years from diagnosis, we will then say to them on day one, stop taking your medication, both for your blood pressure and for your diabetes. So we're going to get them both sorted by losing weight. So on day one, stop those medications and start on a low-calorie diet, 850 calories a day, which is a lot less than you normally eat, but not sort of critically low, not impossibly low. We're going to use a formula diet because that's what people said that they preferred to use, but you could use food-based approaches. The difficulty with using food was that people get tempted into having a bit more and a bit more and a bit more. So to keep it clean and simple, we said, right, we'll use a formula diet for the first 12 weeks and then move on to a food-based diet, which is affordable and simple, using ordinary foods, but in the right amounts to try and maintain that weight loss long term. And people did it. The GPs were doubtful. They said, oh, but the patient, if you stop their blood pressure tablets, won't their blood pressures go up again? And the answer was no, they didn't. They fell instead, because weight loss is a much more potent treatment for hypertension than any medication we have. The diabetes doctor said, oh, but most of our patients won't get better. No, almost 9 out of 10 were free from their diabetes if they lost 15 kilograms, 2 stones in weight. So it was an outrageous success. And the health services had said, if 20% of our patients can get a remission, freedom from diabetes at 1 year, we have to start changing how we look after this disease. In fact, we got almost 50%. Not everybody managed to lose weight, sadly, but those who did got free from the disease. And so within a very short time, the National Health Services in Scotland and in England and Wales and then Northern Ireland, all the separate health services put into place a plan to offer remission of diabetes as early as possible in the course of the disease. And since that time, we've managed to follow people up for up to 5 years and show that their general health improved. They had less hospital admissions for various things. They had less complications of diabetes within the 5 years if they got a remission. And other people have now started to do research on the back of this, and they've shown that there are less heart attacks and less deaths in people who are able to lose weight and get remission of their diabetes. These are big observational studies elsewhere. So I think what we've done is to upend the paradigm, the model of what we thought type 2 diabetes was, to understand that it's actually a manageable, reversible, if you like the word, disease. We can get it into remission by substantial weight loss. As people get older, I think it is likely that age and adiposity will catch up with you. So it's possible that people will have to push their weight down towards what is perhaps a more normal body weight. And that, if you're talking body mass index terms, we're probably talking the old-fashioned ideal body weight of BMI of 21, 22, not 24, 25, and certainly not 30 or 35. Over a period of time, if you want to remain in perfectly good health. And of course, the real message here for everybody, not just people with diabetes, is that gaining weight to get into these higher ranges of body mass index is going to bring medical complications in time. And we should not regard a body mass index of 25 or so as normal, except perhaps in some young sportsmen for whom it is perfectly normal. If you're a rugby player or some vigorous, heavy athlete, then a body mass index of 25 or even a little bit higher than that during that period of time is good. But then you have to watch it while you detrain, because it's very easy to turn that into fat and then you're in difficulties.
Is there a best diet, or is it weight control by any means?
Yeah, again, an ideal question. And of course, as soon as we did this direct trial, we used a specific program. It's called Counterweight Plus. It's available now. It started off as a program that we developed in Scotland with the help of the dietitians in Glasgow and in Aberdeen. It then became a spin-out company, and it's now a commercial company, still run by dietitians completely. So it's kind of professionally sound. That could be considered a sort of Rolls-Royce approach. And of course, as soon as we published the results, every Tom, Dick, and Harry said, hello, we've got a diet program. We can do the same thing. In principle, they probably can, but many of them haven't actually produced quite such good evidence. and they weren't worked out quite so fully. But this is now happening. So a lot of diet programs have been examined, and basically everyone who has achieved weight loss by any sound means is getting the same sort of results. So if you use a 5-2 diet, or a time limited eating diet, or any of the sort of the unusual diets, you're going to get the same results if you get the weight loss. There was a big vogue a few years ago for low carb diets. Every scientific study said actually they don't do anything different from anybody else's diet. They've worked for some people, they don't work for other people. Even that will get remissions if you can get the weight loss. So I think the answer is very simply that whatever diet approach is used to get the weight loss will get remissions of diabetes and of hypertension and the other conditions. But the sort of caveat is, if you're going to lose weight on a pretty tight diet, 850 calories, you do want to make sure that it's got the right amount of vitamins and minerals. And that's where the properly worked out diets, things like Counterweight Plus, are properly designed to be entirely safe in that way. Having said that, it's only, to get the weight loss, it takes, most people can do it in 8 weeks, not 12 weeks, if you really put your heart into it. And that isn't long enough that it's going to cause any vitamin deficiencies or mineral deficiencies before moving on to a maintenance type of diet with normal foods.
Yeah, for those not familiar, you did a kind of an aggressive low calorie for 8-12 weeks and then a maintenance. Do you think there's a benefit to that? Or do you think you could achieve the same outcomes with a kind of a longer term, more maintenance type approach? Or do you think that initial shock has some value?
Oh, it has huge value. Dietitians have used the little changes thing and slow for generations, and people are basically hacked off with that. It doesn't work because they're not seeing any immediate benefit. It's awful hard work. It goes on. I mean, a lot of your listeners have got weight problems. A lot of them will have gone off and lost 5% of body weight, by hook or by crook. They've done something. You don't feel any different. You don't look any different. What's the incentive for maintaining that? If you had type 2 diabetes, maybe that is, you can see that go into remission, but it won't happen with 5%. Lose 10, 15 kilograms, talking 1 or 2 stones in weight. People look different. People feel different. Quality of life takes a huge lift, and we've measured it. So we know that that's pretty consistent. And that gives a sort of motivation to carry on. So I think doing it with a bit more of a big bang approach, with a much more intensive approach, has been successful. And it sort of flew in the face of most of the dietitians' teaching over several generations, which was, you don't want to do anything but to shock the system. No, the big shock actually works best. The big bang tends to work best. And also by focusing on this and saying, all right, we're going to really focus on getting a couple of stones in weight loss to really get on top of this disease and make major changes here. That has taken away some of the confusion that lay with previous approaches, which said, oh, you need to change your diet and change your physical activity and change your sleeping pattern and change everything else. That was confusing because the other things, increasing physical activity is great. You feel better, you get stronger, but it doesn't deal with diabetes. It absolutely doesn't. And it doesn't deal with obesity. There are some young men in particular who are able to exercise themselves down to lose weight, but they do it largely by not being in the kitchen quite so much and actually having less calories to eat. So exercise, great for health, great for well-being, especially for mental health, but it does not deal with diabetes. I'm sorry. And I've just reviewed a paper this morning, which was looking specifically at that, came from Jerry McCann and his colleagues, which said weight loss with diet will improve your heart condition and get remission of diabetes. Hard, intensive exercise training may help your heart a bit, but it does not deal with the diabetes. So the big bang approach, good, and focus on that, and don't be distracted down the other avenues that people talk about.
Well, if someone is listening who thinks, right, I like the sound of this, can it be done at home? Do you need to speak to a GP, or are there resources that you would kind of point people towards?
Yeah. Again, perfect question. A very small number of people in the world require radical, dramatic things like bariatric surgery. In fact, bariatric surgery has been a tremendous research tool. It's taught us what happens when people lose a lot of weight. But we can now get there by other means, and we don't need to go down that route and with all its other complications. So another raft of people need medical support using GLP agonists, Mounjaro and Ozempic to lose weight. That's a relatively small proportion of people. Another raft of people need intensive support from dietitians along the lines of the counterweight plus approach. And that can now be done with online. In fact, it's much more effective going online. People who have a weight problem don't like having to trail into clinics and sit in front of doctors and dietitians and be a spectacle. To do it at home with a sympathetic, trained dietitian down the end of the Zoom or the WhatsApp or the telephone seems to work even better. Then there's another raft of people who don't need day-to-day or week-to-week professional support, but do need guidance and signposting towards effective programs. And they may be community programs, maybe private things which you can access yourself. And then there's a huge number of people who've heard about all this and thought, actually, I think I can do this myself. And you and I mean, we all know people with weight problems who have dealt with the problem themselves. They've got on top of the problem. It hasn't interfered with their lives. They're getting on with life. They've controlled the problem by saying no to this, no to that, and I'll have this and I'll have that. You know, I'll live my life in a way which recognizes I've got a weight problem, but isn't going to spoil my life. So things like saying, I will not eat the snacks between meals, and I will not have second helpings. And I'm doing it for a reason, and I know I'm doing it consciously, and that you have to have willpower to do it, and you have to be able to overcome the biological drive to eat, that appetite thing up here. So for most people, they can, at least partly, and in many cases completely, control a weight problem by their hard work. They can overcome their biological drive to eat. Another, and working back up the scale, there are other people who almost get there but need a bit of professional support and psychological guidance, and that comes from dietitians, good dietitians. That can be done online. Another raft need pharmaceutical support from the GLP-1 agonists. So I think that's how it works. Most people, knowing what's required of them and knowing what the consequences of weight gain and diabetes are motivated to say, right, I'm going to make some changes here, and it's not going to spoil my life.
Are all type 2 diabetics treatable? Obviously, some of them didn't have the success in the program. Was that because they didn't adhere to the program, or can you have the diagnosis for too long and it's too late to have the effect, or is everyone treatable?
Yeah, well, firstly, I'm going to correct you, Ian, and you must never do this again. We do not call people living with diabetes diabetics. They are people living with diabetes. So that's the first thing. The question is, what about the people who did not get the remission of their diabetes? Now, that was interesting because if they lost 15 kilograms in the direct trial, 86%, nearly 9 out of 10, were free from diabetes for 1 year and for 2 years, 82%. That leaves about 15%, about 1 in 7 people who did not get a remission of their diabetes. What about them? Well, some of them were very close to remission. So they just needed to lose a bit more weight. Don't forget, these are people who are 5, 6, 7 stones, maybe 10 stones overweight. So losing 2 stones hasn't done the job. They need to lose more, I'm afraid. That's the reality. There were a very small number, and we're talking about 5 out of 150 people who lost the 15 kilograms and saw no improvement in their diabetes at all. Those people, we went back and talked to them afterwards. Some of them had been untruthful about how long they'd had the disease. They'd had it for much longer than they said. They wanted the program, but they actually had their diabetes for 10 years or more. If you have diabetes for 10 years or more, it's much harder to get rid of it. Some of them had other conditions when we went back and talked to them. So, for example, one of them confessed to having had a serious alcohol problem years ago and clearly had damaged his pancreas. There were 2 others who gave histories of recurrent admissions to hospital with abdominal pain. And putting 2 and 2 together, they probably had recurrent pancreatitis, which was to do with their gaining weight and such like. And the pancreatitis, again, does damage to the pancreas, so you can't then get the recovery with weight loss. So this is the sort of thing that we were looking at. These are quite rare people, but it does tell us that not 100% will get a remission. And if you have these sort of histories, that's obviously an impediment.
Now, what would your message be to the people who don't achieve remission? Presumably, you could be quite disappointed, but even if you managed a few stone of weight loss, surely that will still have some measurable benefit on your life trajectory. Is that the kind of thing you still tell people?
Oh, absolutely. Yes. So, I mean, you can never promise that you're going to get a remission of the diabetes. There's a very high likelihood by losing 2 stones or perhaps a bit more. There's a very high likelihood of being clear from the diabetes. And if you can maintain that weight loss, you will maintain that remission a long time. We always say, Not everybody will achieve that, but if you are able to lose that amount of weight, you will see benefits for your blood pressure, for your general health and well-being. Quality of life and mood improve tremendously with that amount of weight loss. And then there's a whole raft of other conditions. Your arthritis will not progress so fast. If you have indigestion, that will get better. There's a whole stack of things which are likely to get better or not get worse so quickly. So you've done yourself a major favor by losing excess weight. There's no benefit to anybody from being overweight. There's one possible exception there, and that is it's often said that people who are substantially overweight are less likely to get pulmonary tuberculosis. That's now such a rare disease that it doesn't come into our thinking. But other than that, there is no benefit whatever from being overweight. And we as a society should be more sympathetic to the people who have become overweight, because it's not their fault. People don't become overweight out of crass idiocy or anything like this. They become overweight because their appetite, their hypothalamus tucked away in behind their eyes there, a little tiny bit of the brain, is driving an appetite designed for survival, to survive the long winter. It's good to put on weight to survive a long winter, and then you lose it in the long winter and do it all again in the summer. But we don't have any long winters. This is not something that is their fault. They have a big, strong appetite, which is why they survived years and years of our prehistory living in caves. We should not be penalizing people or criticizing them for it. And we should be supporting and helping people to do what they know they would like to do. Not one of them wants to be overweight, or very few actually think it's a good idea to be overweight.
I'm always curious with all of these interviews about behavior change. Motivation and sustaining behavior change is obviously a big issue. Did you find any things that worked?
This is a big one. It's a huge one. There are books written about it. There are innumerable behavioral change models which have been invented by psychologists. And often what they've done is to do a retrospective analysis of people who've changed their behavior and say what looks as if it might have played a part here. And you can pull out statistically things which might be helpful, and then say, well, if we put those into place, will that help people in the future? And sadly, they don't often help very much. And we can't measure motivation. We listen to what our patients say, and many of my patients say, I'm immensely strongly motivated to do this. And they go home and it's all different. So motivation is not a thing we've got a handle on. Certainly, the fear tactics, you've got a serious disease which is going to come and do terrible things to you, is not always a good way to go. And in fact, people can then go into some sort of denial. I don't feel bad today, I'm going to just carry on. So we don't have easy ways to do that. Certainly, human contact, human support is effective. And that support can come from a supportive partner, home partner, family member, or it can come from a professional route. And very often it's the friendly nurse in the practice who says, come on, I'm going to weigh you every month or weigh you every week or whatever you want. Or somebody will chum you along to the Weight Watchers clinic or whichever route you're using. If you're doing that and you feel supported in going, as well as when you're actually at it, the transition from home to your behavior, which might be shopping, or it might be going to a clinic, or it might be going to a gym or a class or something like this. If you're supported in the transition from home to that place or that activity, as well as by the people you meet there, that gives you a bit of a lift as well. So these are very simple things. Often the supportive behaviors are actually in some way distracting from what you're doing. So people who have a weight problem commonly eat more when they're on their own, commonly eat more in the evenings. So you say, okay, let's find a way so that you're not on your own and that you have something else to do in the evenings. Taking up an evening class, there's 101 things which can be offered, but people have to be receptive to do it and have to understand that this is actually doing a positive thing for their health, as well as going to the motor mechanics evening class or the flower arranging evening class, or going to learn French with a group of whatever it might be. So offering people things that they can do to take them out from their current rut, and being supported in doing that by other people around them is often very beneficial. I think a doctor saying, I think you should start going to the concerts at the concert hall or something, absolutely doesn't work. But if somebody near to you says, come on, I'm going down to the People's Palace, I've never been, haven't been for years, come on and do it with me, that's a very big positive thing, rather than somebody telling you to do something.
So let's talk about prevention. Presumably, that's always the best thing. Firstly, I wanted to ask you about prediabetes. Should we be testing more routinely for it? And should we be managing it more aggressively?
For both of those things, yes. But the only reason for testing is to do something about it. And up until now, we didn't know what to do about it. We don't treat pre-diabetes with medication, for example. So a lot of doctors said, if I don't have a drug for it, I'm not going to test for it. That is wrong, 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 because we can do something very, very positive for pre-diabetes. And we have very good evidence that losing quite a modest amount of weight, we're only talking about 1 stone here, will knock back the risk of developing diabetes and the sort of long-term consequences that over up to 30 years benefit from getting people to lose around 1 stone in weight if they have pre-diabetes. So yes, we should be testing more. It's a very simple test to do. We have risk scores that people can do in local shops or the library or anywhere to see am I on the ladder that needs a test. The test is simple. It's a little finger prick test that almost costs nothing. It's very cheap, and it'll give people a steer. And then we should do something about it. Absolutely.
What for you would be your best tips for health and longevity? Even just thinking nutrition first off, but if you have any others on exercise, stress, sleep, or whatever, but what would be your general tips for good, decent lifestyle?
Funnily enough, I was asked this in an interview for the British Medical Journal a few years ago. And what I said, well, for me, I can step away from all the nonsense that's spoken in the social media and the corruption of science by people who are actually trying to make money out of you. I walked past a shop in the centre of Glasgow today, which sells health foods, supplements, and I'm prepared to challenge them. Is there any evidence that any of the products in this huge shop does anything for anybody's health at all? And the answer is no. They don't have evidence for any of this stuff. They're selling foods to people on their ignorance and fear, if you like. So my answer was mountains, music, and medicine. And medicine for me is my profession. So you could put something else. If you're not a doctor, you can put in your passion in terms of your occupation or your hobbies. And then music and mountains. Mountains means I can get up there, I'll be in the open air, clean air. I can exercise as much as I like, and I like it a lot. And I can see everything that goes into the mountains, which might be the rocks, it might be the flowers, it might be the birds, it might be the animals, it might be the people I meet on the mountains. And similarly with music, well, I happen to be a bit of a musician, and I love music. I love playing music. I love making music with other people. I love the environment of being amongst other musicians. And I find that a very supportive environment. So I'm looking for a human environment which is supportive in other ways than your family is. And I think probably that's where I would leave it.
And what are your top 3 nutrition tips, or just some top tips?
We did produce 10 top tips some years ago for nutrition education, which were much more complicated. There isn't a simple 3-point fix to nutrition. Nutrition involves every little element under 27 essential nutrients, which every cell in your body needs in a certain amount. They all have to get there at the right time, at the right place. You've got a raft of metabolic processes which are ensuring that what you swallow gets modified, put in the right places, and gets to the cells in the right way. And I think there isn't a single perfect diet. In general, traditional diets work best. Traditional diets around the world have evolved over centuries and centuries, oddly, to provide really good matches for the human requirement. And very often, traditional diets involve a consumption of a cereal, which might be oats in Scotland, or barley, or wheat, or rice, or occasionally maize. I don't know if maize is so good, together with a pulse or a legume, so peas, beans, lentils. And that mix of a staple high carbohydrate food together with the high protein vegetables, the pulses, the peas, beans, and lentils, gives a huge, solid basis on which you can then add small amounts of other things as available. So most traditional diets are not high in meat, but they're high in those other things. They're not high in fish, although if you live by the seaside, you get much more fish, and that is a major positive. And I think the more fish we can have, the better. But we are acutely aware of the fact that the seas are being depleted by quite inappropriate fishing in many cases, mopping up small fish that should be left there.
Professor Lean, thank you very much. We usually just say to the speaker, if they wanted just to leave the listeners with one final little take-home kind of point, what would that be?
I'll enjoy a piece of fruit, and I'm happy to have my piece of fruit with every meal in the day, and I think you should do the same. And I eat fruit between meals as well. That's not snacking. That's allowed because it's fruit.
Professor Lean, thank you so much for joining me today.
Very nice. Thank you. Cheerio.